This is Dr. Hessel dictating the podcast on preoperative airway evaluation, prediction of difficult airway, due on Tuesday, August 6th. This is some reading resources that I suggest to you. In addition, I think this chapter from Fleischer's Evidence-Based Practice of Anesthesia is extremely relevant to this discussion. I've also provided a bibliography posted on Wiki and an expanded version of this podcast on Wiki. These two articles on management of difficult airway are certainly ones you should have in your library and you should be familiar with and review periodically. I'm going to discuss the significance of difficult airway, the definitions of difficult airway, incidence, and prediction. Competence in airway management, essential attributes of an anesthesiologist, and key to this, the ability to assess a patient for features that correlate with difficult management. Difficulties or failed airways are a major cause of anesthesia morbidity and mortality, as listed on this slide. Difficult or failed airway account for about 2% of all anesthesia-related mortality. The practice guidelines define a difficult airway as a situation in which a conventionally trained anesthesiologist experiences difficulties with any aspect of airway management. Difficult airways can include a wide variety of abnormalities, which are summarized on this slide. First, I'm going to discuss the incidence of these various types of difficult airways. The incidence depends on operator experience, patient factors, and other circumstances. The definition of difficult mask ventilation is the inability to keep the saturation over 90% or to prevent or reverse signs of inadequate ventilation. A number of papers have addressed this, and the incidence of difficult mask ventilation has ranged from somewhere between 0.1% to 5%. In this prospective study, he identified mask airway as being awkward in 17%, difficult in 8%, and impossible in this study in none. This is another classification of the severity of the difficult mask in which you needed an oral airway, about 20% in which you required two hands or muscle relaxant, about 1.5% in which you were unable to mask ventilate with or without muscle relaxant in about 0.2%. Notice the incidence, forget that. In another study, they found that the incidence of difficult mask ventilation was about 2%, difficult laryngoscopy about 4%, and difficult both about 0.4%. The incidence of difficult laryngoscopy is usually defined as a difficult view, defined as a class 3 or 4 view, which occurs in somewhere between 1 and 13% of cases. We'll go into this a little more later. In this interesting study of the incidence of a difficult video laryngoscopy, they found when used as the primary technique, it failed in 2%. When used when you predicted a difficult airway, it failed in about 4%. And when used after a failed direct laryngoscopy, it failed in 6%. i.e., it's not always perfect. The incidence of difficult endotracheal intubation varies between 1 and 4%. This was defined by the ASA as required more than 3 attempts or required longer than 10 minutes. The incidence of failed intubation, according to Benyamoff, is somewhere between 0.05 and 0.4%. In this study reviewed by Goddard and Hubbard, the incidence of failed intubation in surgery was about 5 in 10,000, and in OB about 1 to 0.4%. The incidence of the dreaded complication of cannot intubate, cannot ventilate, is quite low, estimated between 1 in a million and 2 in 10,000. Now let's turn to predicting a difficult airway, and unfortunately the bottom line is we're not very good. In this interesting study of anesthesiologists' ability to predict a difficult airway in over nearly 200,000 patients, they found that when difficult airway was anticipated, in only 22% was it truly difficult, i.e. a false positive rate of 78%. When a difficult mask ventilation was predicted, it occurred in only about 5%. It was not anticipated in about 94%. When a difficult intubation was anticipated, it was difficult in only a quarter. In other words, there was a false positive rate of 75%. When a difficult intubation was anticipated, it occurred in only 2%. In other words, a false negative rate of 93%. I'm sorry, I misstated that. When there was a difficult intubation, which occurred in about 3,000 patients, it was not anticipated in 93%. In other words, a false negative rate of 93% based on pre-op evaluation. Based on this pessimistic viewpoint, let's talk about how we can assess the airway. Rosenblatt, in this paper that I recommend to you, discuss pre-op planning for airway management. He mentioned first you should talk about or consider, is airway management is necessary? Obviously, this is true in all anesthesia patients. Will direct laryngoscopy or tracheal intubation be straightforward? Can a supralaryngeal airway be used? Is there aspiration risk? And in event of airway failure, will the patient tolerate a period of apnea? He stated that the ability to visualize the larynx and intubate depends on alignment of one eye to the larynx. Although the sniffing position improves this, the rest of this alignment depends on the ability to displace the tongue, and this depends on the size of the tongue and the mandibular space. The size of the tongue is predicted by the Mallampati score, but the mandibular space is predicted more on the thyromental distance and the submandibular distance. This is the classic use of the sniffing position, which improves alignment but doesn't solve the problem. Maximum extension of the head on the cervical spine is important. Normally it is 35%, and the advantage is that it increases mouth opening and allows optimal alignment of the larynx. This shows the benefit of atlanto-occipital extension on mouth opening. These are some of the factors that we should consider in assessing the airway. History of prior difficulties, but as I've indicated, there are high rates of both false positive and false negative. Review of prior anesthetic record, but this may be misleading and is influenced by optimism or the skill of the operator. The physical examination, and we're going to talk more about this in a few minutes. Multivariable prediction methods, and the use of special studies such as endoscopy, radiologic study, ultrasound, and consultation. Now, does a documented history of previous difficult tracheal intubation predict subsequent difficult? Unfortunately, based on this interesting study, this is not very accurate. What they did was review data from the Danish anesthesia database of over 100,000 patients who then underwent a repeat general anesthesia with an attempt at tracheal intubation. About 1% of patients had evidence of a difficult intubation in the past, and 0.25% had evidence of a difficult intubation in the past. Did this predict the consequence of the subsequent attempt? When they had a history of a prior difficult intubation, only 25% of these patients had a difficult intubation at the repeat anesthetic. In other words, there was a 75% false positive prediction. On the other hand, 5% of those who did not have a difficult intubation previously turned out to have a difficult intubation on the subsequent. In other words, a 5% false negative. When they had a history of a prior failed intubation, in only 30% did it fail on the repeat. In other words, there was a 70% false positive rate. On the other hand, when they did not have a history of a failed intubation on the previous attempt, 2% had a failed intubation on the repeat anesthetic, of 2% false negative rate. So you can't rely exclusively on the past history. This is from Barish's latest edition of Fundamentals, indicating factors that are risk factors for difficult laryngeal mask ventilation or supraglottic airway. And this is a list from that paper, from that chapter, on pathologic conditions, both congenital and acquired infections that are risk for difficult airway management, and other conditions such as arthritis, tumors, trauma, and miscellaneous conditions that may predict difficult airway management. On this slide are summarized the components that you are all familiar with of what we are taught for pre-op airway evaluation. The length of the upper incisors, the overbite, the relation of maxillary and mandible incisors, in other words, the ability to protrude the lower incisors beyond the upper lip, the so-called upper lip bite test, inner incisor distance, visibility of the uvula, shape of the palate, compliance of the mandibular space, thyromental distance, etc. These are, again, some of the indices that are used to predict difficult airway. This is from the chapter in Chestnut written by Benyamoff, which indicates these various examinations and what they consider the minimal acceptable values for the inner incisor distance, the oropharyngeal class, the configuration of the palate, mandibular space length, or the thyromental distance, length of the neck, thickness of the neck, and range of motion of the neck. This is a study in which they looked at factors that predicted difficult mask ventilation or a difficult endotracheal intubation. Note the risk factors for difficult mask ventilation and the risk factors for difficult endotracheal intubation. What are the factors associated with difficult airway? Unfortunately, objective data are hard to come by, partly because of the various definitions of difficult airway. These are some of the difficulties, and as far as predictors, there are single predictors and multiple factors. In analyzing these data, you have to be familiar with statistical measures, and I suggest you review other presentations on statistics in which are discussed sensitivity and specificity, false positive and false negatives, positive and negative predictor value, and the usefulness of receiver-operator curves. These are some of the studies of factors that predict difficult mask ventilation. This is from Barish's latest edition, factors that predict difficult mask ventilation and independent factors that predicted difficult mask ventilation. They found that the presence of beard, high body mass index, lack of teeth, age greater than 50, and history of snoring were all risk factors. This was another study from Yildiz indicating risk factors for difficult mask ventilation, including Mallampati score, gender, history of snoring. This I've previously described factors for risk of difficult mask ventilation. And this was a study of prediction of impossible mask ventilation. They found that it was impossible to mask ventilate in about 0.15% of patients. And this shows the various factors that were associated with an impossible mask ventilation. These were independent predictors of impossible mask ventilation, the most powerful being neck radiation changes, other factors, males, gender, sleep apnea, Mallampati score, and presence of a beard. This is an interesting study in which they studied use of supraglottic airway and analyzed factors that predicted a difficult supraglottic airway. These included scars, radiation mass, thick neck, small thyromental distance, limited cervical motion, and limited experience of the operator. As far as factors predicting difficult intubation, these often are used synonymously with difficult direct laryngoscopy, but Dr. Rosenblatt suggested that perhaps these are outmoded with the development of video laryngoscopes. Mace analyzed or emphasized the elements to give the best attempt at conventional laryngoscopy. Reasonable experience provider, no significant muscle tone, and I would interpret this as full muscle relaxation, optimal sniffing position, proper blade length and type, and use of laryngeal manipulation. Factors associated with difficult laryngoscopy or difficult intubation, again, are difficult to come by because of variable definitions. But the commonly used definition is the high Comac-Lehone grade. You're familiar with this. The traditional grade 1, see everything. Grade 2, only the areoglottic folds. Grade 3, only the epiglottis. And grade 4, you can't see the epiglottis. This has been broken down into subgroups from the original classification. This classification divides group 2 into partial view of the glottis of the cords, and only able to see the areoglottic arytenoids, but none or only the posterior part of the vocal cords. So this would be 2A and 2B. Cook then modified 3 into 3A when you can only see the epiglottis, but it can be lifted, versus group 3B, which is the most ominous, when the epiglottis can be seen, but it can't be lifted. So I suggest adding 1, 2A, 2B, and then 3A and 3B. Cook analyzed the significance of these views. He said that when you have a 1 or 2A, it's usually easy and rarely requires adjuncts. When it's a 2B or a 3A, in other words, only the areoepiglottic folds or only the epiglottis, but the epiglottis is mobile, you're likely to require gum bougie, or I would add a fiber optic laryngoscope, or if it's 3B or 4, then it's unlikely that you can use a gum bougie, and in this case, perhaps fiber optic laryngoscope or some other adjuncts may be required. On the other hand, a poor view doesn't always predict a difficult intubation. In this interesting study of over 1,000 patients, over 100 had a class 3 or 4. In almost half of these, intubation was succeeded in the first attempt, and in another 40% with repeat attempts, and only 15% required an alternate approach. These are some of the conditions that are associated with a difficult rigid laryngoscope. And these are also summarized on this repeat of a previous slide I showed you. In this review article I previously mentioned, these authors examined various single predictors, which are well familiar here. And they concluded that no test has adequate sensitivity without substantial false positives. They have a low sensitivity and positive predictive value. The sensitivity is only about 30 to 70%, and I refer you to the details in the table from this paper by these authors. This is from Barish's Clinical Anesthesia Fundamentals, and shows the relatively poor sensitivity and specificity of these traditional values. And this is another paper, again showing the relatively poor sensitivity and specificity of these other parameters that are traditionally used. You're all familiar with the Mallampati classification. It's important to remember that these should be done sitting up when the patient is asked to stick out their tongue, but are not asked to phonate. Again, you're familiar with the classification here. In this review paper I referred to a number of times, you notice that the sensitivity, specificity, and positive predictive value are all rather poor. On the other hand, craniocervical extension improves the predictive value of the Mallampati classification. They found that the Mallampati score improved about a half a point when they added cervical extension, which increases mouth opening. Another popular test is the upper lip bite test. You're familiar with this. Class 1, when the lower incisors will reach the vermilion line. Class 2 and Class 3 when it cannot touch the upper lip. You see the accuracy is better than Mallampati. Sensitivity is about the same. Specificity is better. Positive predictive value is better. And negative predictive value trivially better. Can't get my tongue around that. This was another study of the upper lip bite test. They found that about 2/3 were Class 1, a third Class 2, and only 8% were Class 3. These patients, about 86% were Class 3. I'm sorry, forget that. Sensitivity was about 28%, specificity about 93%, and the positive predictive value about 34%, negative predictive value about 91%. This was a meta-analysis of bedside screening by Shiga, notable article that many people refer to. And you see that each test yield a poor to moderate sensitivity and a moderate to fair specificity. And the combination of tests added some advantage, but the clinical value of bedside screening for predicting difficult area remains limited. What about obesity? The data are conflicting. When controlled for other factors, it may not be an independent risk factor. On the other hand, neck circumference per se seems to be a useful predictor. What about combined predictors? Many different factors have been combined as summarized on this slide. Again, this review article looked at combined predictors. See their study. They found that none have provided satisfactory results in terms of sensitivity and specificity. And the problem with special populations which have not been well studied, such as those listed on this slide. In Barish's, he noted that obviously the more risk factors you use, the number of risk factors present increases the risk of a difficult airway, but none are very, very helpful. In summary, these authors said that reliable prediction of difficult intubation remains unsolved and likely remains a decision based on clinical judgment. And I'm not sure what we base our clinical judgment on. Finally, practitioners should always be prepared for having a difficult airway cart readily available and practicing difficult airway drills and special techniques that are helpful in managing the patient with difficult airway. This was, again, I think I may have mentioned this earlier, predictors of failure of video laryngoscopy. from this study by Aziz. Difficult mask ventilation combined with difficult laryngoscopy. This was a multi-center study. They found that a difficult mask ventilation occurred at about 2%, difficult laryngoscopy at about 4%, and difficult both in about 0.4%. These were some of the factors that they used in developing a predictive score for a difficult mask ventilation plus difficult laryngoscopy. And they then, based on their predictive score, classified patients as class 1 with few risk factors, class 5 with 7 or more risk factors, and the odds ratio when they had these risk factors were 18%. In the almost 700 patients who had difficult mask ventilation and difficult laryngoscopy, about a fifth were intubated by DL, and about the rest were, all but one were intubated by other techniques, and only one out of these 700 required a cricothyroidotomy. So this is a bad situation. It can be somewhat predicted by this classification system, but occasionally one needs to resort to surgical airway. This study by Rosenblatt emphasized that use of a preoperative endoscopic airway evaluation using fiber optic scope passed through the nose could be helpful in planning airway management, and I think it's a skill that we all ought to learn and use. Finally, we always rely on a surgical airway, but that doesn't always work, as I mentioned before. And in this nice article on difficult cricothyroidotomy, Dr. Mace summarized a algorithm for predicting a difficult cricothyroidotomy: a disrupted airway, hematoma, obese, access problems, radiation, and tumors. Finally, it's not over till it's over. And in this textbook, Barish has summarized the various risks of post-extubation problems and how this can be anticipated. Pre-existing and paradoxical vocal cord motion, various types of surgery, edema, tracheomalacia, and other conditions that should make you concerned about the risk of post-extubation complications. Finally, remember the risks of difficult airway are heightened outside of the operating room, in the ICU, on the hospital wards, in the ER, and prior to hospital. And I recommend these two articles in the British Journal of Anesthesia that address the risk of difficult airway outside of the operating room. In summary, predicting a difficult direct laryngoscopy remains a large part an enigma. Commonly used indices may not only be less predictive than originally thought, but they may be misleading. The advent of video laryngoscope may make some of these deficits irrelevant, and new criteria need to be explored. Finally, remember, oxygenation, not intubation, is what is important. The aim should be to avoid hypoxia, not to intubate. Difficult mask ventilation may contribute more to hypoxia than difficult intubation. Both can be alleviated by supraglottic airway. Consider earlier use of the supraglottic airway first. In summary, the ability to manage the airway is a key characteristic of anesthesiologists. Difficulties with establishing an airway is a major cause of adverse outcome. Difficulties may be anticipated by a thorough history. Unfortunately, no combined parameters have perfect predictive ability. Therefore, one must always be prepared to manage any of these difficulties, ranging from inability to ventilate with a mask to cannot intubate, cannot ventilate. I have appended at the bottom study questions which you will be asked to answer. I suggest you answer 10 of these 17. 2 through 7 are listed on this slide.